Your position has been reclassified as non-essential personnel under our updated workforce categorization framework. That's what the email from HR Director Karen Walsh announced on a Friday afternoon in February 2024, sent with the bureaucratic efficiency of someone who believed workforce value could be determined by checking boxes on organizational charts rather than understanding who actually kept operations running during crises. Non-essential personnel. I'd been IT systems administrator at Meridian Healthcare Group for 11 years, managing the technical infrastructure that kept electronic health records accessible, medical imaging systems operational, and clinical applications running 24 hours a day across 3 hospitals and 17 outpatient facilities serving 230,000 patients annually. But according to Karen, our HR director who'd joined Meridian 6 months earlier from a retail company where she'd specialized in workforce optimization, my role could be categorized as non-essential because I didn't provide direct patient care and my work happened in server rooms rather than examination rooms, which meant that during cost-cutting initiatives or emergency situations, I could be furloughed or reassigned without impacting critical healthcare operations. I'm Nicole Martinez, and I sat at my desk at Meridian Healthcare reading Karen's reclassification email while knowing exactly which systems would fail without proper IT support and exactly what would happen when the disaster recovery plan got activated during an actual emergency requiring that a non-essential administrator who designed every backup system and documented every recovery procedure. 11 years, 7 months, and 21 days of ensuring medical systems stayed online so doctors could access patient records during emergencies, maintaining redundant infrastructure so that system failures didn't delay care, and building disaster recovery capabilities that could restore critical operations after outages. And Karen had decided that because I didn't wear scrubs or interact directly with patients, my work was non-essential support that could be interrupted without consequences. I wasn't the surgeon who performed procedures or the nurse who administered medications. I drove a 2016 Subaru Outback with 128,000 miles on it and technical documentation binders in my trunk because I reviewed system architecture diagrams during evenings preparing for maintenance windows when other people watched television. I lived in a small house in suburban Pittsburgh with a home office containing filing cabinets full of disaster recovery plans, system configuration documents, and incident response procedures that I developed meticulously because healthcare IT infrastructure requires detailed documentation of every system dependency and recovery step. My walls had network topology maps showing how data flowed between hospitals, clinics, and data centers, maps that looked like abstract art to visitors but represented the technical foundation that kept Meridian's healthcare operations functioning. I was methodical, obsessive about redundancy and failover capabilities, protective of system reliability that medical professionals depended on even if they didn't think about who maintained it, and apparently non-essential to an HR director who thought IT work was just fixing computers rather than maintaining the critical infrastructure that enabled modern healthcare delivery. The trouble had started 6 months earlier when Meridian Healthcare had hired Karen Walsh as HR director to optimize workforce management and implement cost-efficient staffing models. Karen came from retail workforce management where she'd specialized in categorizing employees as essential versus non-essential to justify different compensation levels, benefit packages, and layoff priorities during business downturns. She had that efficiency-focused mindset, talking about workforce optimization, headcount rationalization, and aligning personnel costs with revenue generation, that worked in retail environments but became dangerous when applied to healthcare operations where system failures could literally kill patients. Karen's first major initiative had been implementing a workforce categorization framework that classified every position as either essential or non-essential based primarily on whether employees provided direct patient care. Her framework was simple: doctors, nurses, medical technicians, and other clinical staff were essential because they directly treated patients. Administrative staff, IT personnel, facilities maintenance, and other support roles were non-essential because they didn't directly provide medical care. What Karen didn't understand, and what she'd refused to learn despite multiple attempts by myself and others to explain, was that healthcare operations depend on complex technical infrastructure that requires specialized expertise to maintain. Electronic health record systems don't fix themselves. Medical imaging equipment requires network connectivity and database access. Laboratory systems need integration with ordering and results reporting platforms. When any of these systems fail, clinical staff can't provide effective patient care regardless of how skilled they are. Karen's categorization framework had classified me as non-essential because my job title was IT Systems Administrator, and I worked in data centers rather than patient care areas. Never mind that I maintained the EHR system that every doctor and nurse used to access patient records. Never mind that I managed the network infrastructure connecting operating rooms to imaging systems. Never mind that I designed disaster recovery systems that could restore operations after major failures. According to Karen's framework, I was administrative support that could be deprioritized during workforce reductions or emergency situations. I tried to explain this to Karen in September 2023 when she'd first proposed the categorization framework. Karen, healthcare IT isn't optional administrative support. When the EHR system goes down, doctors can't access medication lists or lab results. When imaging networks fail, radiologists can't view scans. When clinical applications are offline, patient care gets delayed or even stopped. IT systems administration is critical infrastructure support that enables all clinical operations. Karen had responded dismissively. Nicole, I understand you believe your role is important, but we need to maintain realistic categorization. Essential personnel are those who directly provide patient care. IT support is important but not essential in the same way clinical staff are essential. This categorization helps us make workforce decisions during emergencies or cost reduction initiatives. I pointed out that Meridian's own disaster recovery plan, which had been approved by the board and was required by healthcare regulations, explicitly designated IT systems administrators as critical personnel who must be available during emergencies to restore operations. Karen had brushed this aside as technical documentation that didn't override HR's workforce management authority. In October 2023, I'd escalated to Meridian's CIO, Robert Chin, explaining that Karen's categorization would create problems during actual emergencies when IT expertise was needed to restore failed systems. Robert had agreed with my concerns but had said HR workforce categorization was outside IT's authority and that he'd raised the issue with executive leadership without success. By February 2024, Karen had finalized and implemented her workforce framework. I was officially categorized as non-essential. This classification meant I'd be lower priority for retention during layoffs, lower priority for compensation increases during budget constraints, and potentially excluded from emergency response during disasters if HR determined that only essential personnel were needed on-site. The reclassification felt insulting and demonstrated profound misunderstanding of what kept healthcare operations functioning. But I continued doing my job, maintaining systems, updating disaster recovery documentation, and ensuring Meridian's technical infrastructure remained reliable even if HR didn't understand or value that reliability. Now about 75% of you think I'm about to deliberately cause a system failure to prove my value, and you're completely wrong. Subscribe right now, because what actually happens is that disasters don't coordinate with HR categorization frameworks, and when actual emergencies require disaster recovery expertise, organizations discover exactly who's essential to restoration regardless of what administrative policies say. On March 14, 2024, at 2:47 a.m., Meridian Healthcare's primary data center experienced a catastrophic cooling system failure. The data center housed the servers running Meridian's electronic health record system, medical imaging repositories, laboratory information systems, and clinical applications used across all facilities. When the cooling system failed, temperatures in the data center rose rapidly, and automated safety systems shut down servers to prevent heat damage. By 3:15 a.m., Meridian's electronic health record system was completely offline. Doctors and nurses arriving for morning shifts couldn't access patient records. Emergency department physicians couldn't look up medication allergies or previous test results. Operating rooms couldn't pull up surgical histories or imaging studies. The outage affected all 3 hospitals and 17 clinics simultaneously. At 3:42 a.m., I received an automated alert on my phone from Meridian's monitoring systems indicating the data center outage. I was home asleep, but I'd configured alerts for critical failures that required immediate response. I got up, checked the alert details, and immediately understood the severity. Primary data center offline meant all core clinical systems were down and would require disaster recovery procedures to restore operations using our backup data center. I called Meridian's IT operations manager, David Park, who was the on-call escalation contact. David confirmed the situation: primary data center cooling failure, servers automatically shut down, and all clinical systems offline. David asked me to come to Meridian's main hospital immediately to lead disaster recovery efforts. I was dressed and driving to the hospital within 15 minutes. I arrived at Meridian's IT Operations Center at 4:23 a.m. Present were David Park, 2 junior IT technicians who'd been called in, and surprisingly, Karen Walsh from HR, who'd apparently been notified that a major incident was underway and had decided to monitor the situation from an HR perspective. David briefed me on the current status. The primary data center's cooling system had completely failed due to a failed chiller unit. Repair technicians were working on it but estimated 6 to 8 hours before cooling would be restored, and even after cooling was restored we'd need several hours to safely power up servers and verify data integrity. Total estimated recovery time for primary data center, 12 to 14 hours. This was exactly the scenario our disaster recovery plan was designed for. Meridian had a backup data center at an alternate location with replicated copies of all critical data. The disaster recovery plan I developed over years outlined specific procedures to activate backup systems, redirect network traffic, and restore clinical applications using the backup infrastructure. Estimated recovery time using disaster recovery procedures, 3 to 4 hours to restore essential systems. I started executing the recovery plan. First priority was restoring the electronic health record system because clinical staff needed patient data to provide safe care. I accessed the backup data center remotely, initiated startup procedures for the backup EHR servers, verified that replicated data was current and complete, and began redirecting network traffic from the failed primary data center to the backup systems. This work required detailed knowledge of system configurations, network architecture, database replication status, and application dependencies, exactly the kind of specialized expertise that I'd built over 11 years and that was documented in the disaster recovery plans I'd written. The junior IT technicians assisting me didn't have this knowledge. They could follow instructions but couldn't make the technical decisions required when recovery procedures didn't go exactly as documented. At 5:47 a.m., I successfully restored the electronic health record system using backup infrastructure. Clinical staff across all facilities could access patient records again. Morning shift. Physicians and nurses could review medication lists, lab results, and treatment plans. Emergency department operations resumed normal functionality. Karen Walsh, who'd been observing from the IT Operations Center, approached me. "Nicole, I didn't realize system recovery was this complex. How much longer until everything is back online?" I explained that I'd restored the most critical system first, the EHR, and was now working through other clinical systems in priority order based on patient care impact. Next priorities were medical imaging access, laboratory systems, and operating room applications. Estimated time to restore all essential clinical systems, approximately 2 more hours. Karen asked who else at Meridian could perform this recovery work if I wasn't available. I explained that I'd trained David Park and one other senior IT engineer on disaster recovery procedures, but they had less experience with the full scope of Meridian's infrastructure and would take longer to execute the recovery. The junior technicians couldn't lead disaster recovery. They didn't have sufficient knowledge of system interdependencies and recovery sequencing. At 6:15 a.m., Robert Chin, Meridian's CIO, arrived at the operations center. Robert had been briefed on the outage and wanted a status update. I explained that the EHR was restored, that I was working through other critical systems, and that we were on track to have all essential clinical operations restored by 8 a.m. before peak patient volume. Robert asked about the failed primary data center. I explained that even after cooling was restored and servers powered back up, we'd need extensive testing to verify data integrity and system stability before transitioning operations back from backup to primary infrastructure. Full restoration to primary systems would take several days of careful validation. At 7:52 a.m., I completed restoration of all critical clinical systems using backup infrastructure. Doctors could access medical imaging. Laboratories could process orders and report results. Operating rooms had access to surgical planning systems. Clinics could schedule appointments and document patient visits. All essential healthcare operations were functioning on backup systems while the primary data center underwent repair. At 8:30 a.m., Meridian's executive team held an emergency meeting to review the incident and recovery. Present were CEO Michael Chang, COO Susan Rodriguez, CFO Thomas Park, CIO Robert Chen, and HR Director Karen Walsh. I was asked to attend to explain the technical recovery process. Michael asked me to walk through what had happened and how we'd restored operations. I explained the cooling failure, the automatic server shutdown, the activation of disaster recovery procedures, and the systematic restoration of clinical systems using backup infrastructure. I noted that the disaster recovery plan I developed had worked exactly as designed and that we'd restored essential operations within 4 hours of the initial failure. Susan Rodriguez asked a pointed question, "Nicole, what would have happened if you weren't available to lead this recovery?" I responded honestly, David Park and our senior IT engineer have been trained on disaster recovery procedures and could have executed the recovery, but it would have taken longer because they have less experience with the complete infrastructure. The junior IT staff couldn't have led the recovery, they don't have the necessary knowledge. If none of the experienced IT administrators were available, we'd have needed to bring in external consultants, which would have delayed recovery by hours and potentially longer if consultants needed time to understand our specific environment. Michael looked at Karen. When Nicole says, if experienced IT administrators weren't available, is there any scenario under our HR policies where Nicole or David might not be available during an emergency like this? Karen shifted uncomfortably. Under the workforce categorization framework, IT administrators are classified as non-essential personnel. During emergency situations, HR guidelines prioritize essential personnel for on-site access and emergency compensation. Non-essential personnel might be restricted from facilities or might not be authorized for emergency callback depending on the situation. Michael's expression changed. You're telling me that the person who just restored our entire clinical infrastructure in 4 hours is classified as non-essential? And that under HR policies, she might have been prevented from responding to this emergency? Karen tried to explain her categorization logic, direct patient care versus support functions. Michael cut her off. Karen, without Nicole's work this morning, our doctors couldn't access patient records, our emergency departments couldn't provide safe care, and our operating rooms would have had to cancel surgeries. That's not support work, that's critical infrastructure that enables all healthcare operations. I don't care that Nicole works in data centers instead of patient care areas. I care that when our systems failed, she restored them in 4 hours using disaster recovery capabilities that she designed and documented. That's essential. Over the next week, several things happened rapidly. On March 15, Michael Chang ordered a comprehensive review of HR's workforce categorization framework. On March 18, Robert Chen presented documentation showing that Meridian's board-approved disaster recovery plan explicitly designated IT systems administrators as critical personnel required for emergency response. On March 21, Michael directed that all personnel explicitly identified as critical in regulatory-required disaster recovery and business continuity plans must be classified as essential regardless of whether they provided direct patient care. On March 22, Karen Walsh was asked to revise the workforce categorization framework to align with disaster recovery requirements. Karen resisted, arguing that HR should maintain authority over workforce classification. On March 25, Michael overrode Karen's objections and issued an executive directive that IT systems administrators responsible for critical infrastructure were to be reclassified as essential personnel effective immediately. On March 28, I received official notification that my position had been reclassified from non-essential to essential personnel, which meant priority retention during workforce reductions, eligibility for emergency response compensation, and recognition that my role was critical to Meridian's operations. On April 5, Karen Walsh resigned from Meridian Healthcare. According to organizational gossip, the board had lost confidence in her judgment after the data center incident demonstrated that her categorization framework didn't reflect operational reality. Karen took a position at another retail company where she could apply workforce optimization strategies without the complications of life-critical infrastructure. On April 12, Robert Chen called me into his office. "Nicole, I've been reviewing your contributions over 11 years and particularly your work during the data center incident. You designed disaster recovery systems that worked exactly as needed, you documented procedures that enabled rapid recovery, and you executed restoration under pressure. The executive team wants to recognize this expertise with expanded responsibilities. I was promoted to Director of IT Infrastructure and Disaster Recovery, reporting directly to Robert. My salary increased from $97,000 to $142,000, a 46% increase. I was given additional staff, expanded budget authority, and explicit executive sponsorship for disaster recovery and business continuity initiatives. In June 2024, I attended a healthcare IT conference where Karen Walsh was speaking on a panel about workforce management. After her panel, she approached me. "Nicole, I heard you were promoted after the data center incident. That worked out well for you." I looked at her directly. It worked out because I spent 11 years building disaster recovery capabilities that saved Meridian from 12 to 14 hours of clinical systems downtime that would have affected patient care across 3 hospitals. When you classified me as non-essential, you demonstrated that you didn't understand how healthcare actually operates. Clinical staff can't provide care without functioning IT systems. When those systems fail, the people who can restore them aren't optional support, they're critical infrastructure personnel. Karen tried to defend her framework. My categorization was based on standard HR principles about direct versus indirect patient care contribution. I responded, "Your categorization ignored operational reality." When the EHR went down at 3:15 a.m., doctors couldn't access medication lists. When I restored it at 5:47 a.m., they could provide safe care again. That 2.5 hours of my work wasn't indirect contribution. It was directly enabling every single clinical interaction across the entire health system. Your HR principles don't override the reality that modern healthcare depends on functioning technology infrastructure maintained by people with specialized expertise. Karen walked away without responding. If you've ever been the person who keeps everything running from the shadows while others decide you're expendable, you know exactly how this feels. The invisible infrastructure. The thankless preparation. The middle-of-the-night phone calls that nobody remembers until systems fail. And then suddenly everyone remembers who actually keeps the lights on. Hit subscribe if you're tired of watching people who've never fixed anything decide who's essential. Drop a comment about the time someone called your work just IT or just support until the day everything crashed and they realized what just actually meant. Because here's what I learned: your value isn't determined by who understands your job. It's proven by what stops working when you're not there.